just like skittered across the ground, and the one guy looked at the other one and said, "Oh, the Cubs must have won the World Series." But it's not anymore. They did.
All right, we're going to talk about acute coronary syndrome and MI. You guys are going to be having a little bit of lecture about 12 leads from Megan at some point. It's going to be one of the classes. She's going to talk about that. So we're just going to go through quickly this part. We're going to define the acute coronary syndrome, review the American Heart Association 2010 guidelines, although the 2015 is out, and review STEMI alerts, ST elevation, MIs, that kind of thing. So acute coronary syndrome is basically just a term for the sudden reduced blood flow to the heart. Hopefully we can get to it before the damage is done. Again, just like brain is muscle, heart is muscle as well. So the quicker we see the signs and we start acting on it, we'll save the heart. And then acute coronary syndrome treatments vary depending on your size, your signs, your gender, symptoms, and overall health condition, basically just like everything else. So the 3 I's of infarction starts with ischemia. And do you guys look at 12-lead EKGs at all?
If they've been scanned in, but I don't think we see them otherwise.
Have you ever had a 12-lead EKG class?
Just my basic, I did monitor teching, so we did basic EKG interpretation, but I wanted
Yeah,
12 lead.
again, even if you YouTube it, but if you get a chance to go to a 12-lead EKG class, very beneficial. Just even for 2 self nurses, not even IMC. If you're a cardiac nurse, it's a good idea. And I got burned one time. I had a patient who came in with an MI, and Dr. Miner, and I've been a nurse for a while, Dr. Miner says to me, does he have a Q wave? And I'm like, Marla, does he have a Q wave? And I'm like, I don't know. And he yelled at me and said, you should know that. I'm like, I will tomorrow. So then I started teaching EKG classes after that. So ischemia, you'll start seeing T-wave inversion with that, and that just means that the damage is starting. There's decreased blood flow, whether it be a clot or plaque, whatever reason, and the myocardial tissue turns pale, not that you see that, but it does. And then injury, you start getting ST elevation, tissue turns blue, and then infarction, you get a significant Q wave, if that's full thickness, and then myocardial tissue turns black. So you don't always get full thickness. Yeah. You won't always see a Q wave.
I was gonna say, when you're saying significant Q wave, is that when, like in medley, when you see the extremes where it almost goes off the register? Is that what you mean by that?
No, it's not the QRS. It's an actual Q wave. And I'll go through that here in a second, and then you'll get more of that with Megan when you go through 12-lead EKGs. But I'll go through that in 1 second. So this is a Q wave. So this is a Q wave actually. So your first, when you get the QRS, your first, it's going to be an upward stroke first, just like a normal QRS you would see. If your first part goes down, that's a Q wave, and that means we used to call them either a non-Q wave MI or a Q wave MI. And you don't, and it's usually a full thickness, like things are going bad fast if you see that. But you won't always see a Q wave, but that's what you're seeing. And then you'll see the ST elevation. So initially, you see the ST elevation, it only has to be 1 millimeter, so one of these tiny little boxes, because you could look at that and say, well, I don't, it doesn't really look significant, it's only a box. Well, that means something's happening. That is an MI. So it doesn't have to be big. You don't have to see tombstones for it to be an MI, but you want to catch it before it gets to tombstones. And the 1 millimeter in your limb leads, which are your limb leads, the 3, and then 2 millimeters in the chest leads, which are the ones, if they're getting a 12 lead, it's the ones they put around the chest, and that's an involving MI. So here you can see everything's kind of baseline, but he's starting to get a little bit of a Q wave. Because you shouldn't see that at all. It should go straight across and then up. What technically the definition of a Q wave is, it has to be a third of the length of the QRS, and this isn't really a third of the length, but this is way more than the third of the length would be. So if it goes down like a third of what that would be, and then goes up, and it has to be a box wide. So a third of the length of the QRS and a box wide to be technically a Q wave. Okay, and then you start seeing the ST elevation, T wave inversion. We'll go through more of that in a second. So here's the evolution of the MI. As it starts, you get the T wave inversion. Within hours of the MI, you get the marked ST elevation and upright T wave. Hours later, you start to see that Q wave. You can see the little dip on there. Again, this is the start of a Q wave. And you get the ST elevation is starting to get this little guy right here that dips down first. Hours to days later, you have the Q wave, your ST segment starts to come down, you'll get a T wave inversion. So if you have a patient that's come in and saying, I had chest pain 2 days ago, and they come in and you get an EKG and you start seeing a Q wave and your ST maybe a little bit elevated, but you've got T wave inversion, it looks a little bit more like this, you know that it's not just starting, that you're already a couple days into it. Days to weeks later, you have this Q wave, and then T wave inversion, and then you have those patients that come in, they're having a procedure done, or they're not coming in for heart problems at all, they're maybe getting a workup or something, get an EKG, and the doctor says, when did you have your heart attack? I said, I never had a heart attack. Well, yeah, you did, because this Q wave tells me that at some point in your life you had a heart attack. But you have no T wave inversion, you have no ST elevation, everything's baseline. It otherwise looks exactly the same as it should for normal, but you have a Q wave. And that means at some point in your life, whether you knew it or not, you had a heart attack. So that's when they're probably going to start doing some cardiac workup before they take that patient to surgery. And this is just, have you guys ever heard about reciprocal changes with EKGs?
Is it multiple leads?
I just never remember which leads to read.
So
together.
when you're looking at reciprocal, so if quick anatomy on the heart. So you got your heart, you've got the three main vessels. You've got the left main, which branches out into the LAD, which is the left anterior descending that goes to the anterior part of the heart, and that's the widowmaker. Technically, the left main is the actual widowmaker, because if your left main, which is the part that comes off and it starts to branch out in the other ones, if that gets occluded, that's blocking off everything to your heart and you're going to die from that. But they call the LAD the widowmaker as well. So you've got your LAD coming down your anterior part, you got your circumflex that goes around to the lateral part of the heart, and then your RCA, which goes around to the inferior part, and then part posterior as well. So, quick 12 lead. If the doctor says this patient's coming in and they're showing changes in their inferior leads, which means it's the right coronary artery, you're looking at 2-3 and AVF. This is the inferior part of the heart that it's showing, and that's the right coronary artery. So you can see here, he's got a Q wave and he's got significant ST elevation. And what's the opposite, technically, of the inferior part is kind of the anterior parts, a little bit of lateral. So I can see here, now if I'm looking at this, the first thing, V1, V2, V3, and V4 are anterior, that's LAD, and there's some septum thrown in there as well. I can see there's T-wave inversion, and I may look at that and I say, you know what, something's going on in the right, or the anterior part of the heart, because look at these changes I have in my anterior leads. But if I look over here and see this, which looks much worse, this is reciprocal changes to the inferior part. So this is worse. So you're going to pay a lot more attention to this if you see it than you will with this. Does that make any sense at all? So those are just reciprocal changes. And that's going to be something that when you go through the class and you get more used to looking at 12-lead EKGs, you'll start to recognize and start to understand. So inferior RCA, V1 through V4 is LAD, anterior. And then 1, AVL, V5 and V6 are circumflex, and those are your lateral leads. And you'll find a lot of things diagrams that will color code them. So they'll have this little thing in purple, these 4 things in red, and these guys in blue or something. So when you're looking at it, you know, if you look at the colors, you'll be able to see which ones are grouped together. Because you can't look at it as a whole, you've got to look at it in segments. And this guy doesn't really tell you anything other than if you have your leads on right. So if it was upright, then you would have, yeah, the leads on somehow wrong. So this AVR doesn't really tell you a whole lot of anything. So here, now I see a huge Q wave and ST elevation. So this sticks out at you right away. I say something bad's going on. And what part of the heart is this? Anterior part. And what vessel is that?
LAD.
Yep, LAD. So the opposite part of the anterior in these cases is usually inferior. So if I look over my inferior leads, I can see T wave inversion, ST depression. So I know that this is probably reciprocal changes. Now here in my 1, AVL, 5, and 6, I got something bad going on here too. So what's probably happening is the patient's having an anterior lateral MI. So it very well could be that either both of the LED and the circumflex are occluding, or I've got something bad going on in my left main. And maybe this just hasn't shown up yet, but it's probably going to. But it's mostly occluding off my LED and my circumflex. What's the acronym for chest pain that we learned in nursing school that we give? Yep, and that hasn't changed, I think, since as long as I've been a nurse. Morphine, oxygen, nitroglycerin, and aspirin. And this is just, we won't go through this, but this is just the ACLS, acute coronary syndrome algorithm. I'll go through a little bit. So a patient comes in, saying they're having chest pain. EMS comes, brings them to us. We're going to put them on the monitor. We're going to get some labs. We're going to get a 12 lead. First thing we're going to do is get some aspirin in them, because we want to give them aspirin as soon as possible if they haven't already taken it home. Nowadays, a lot of people start having chest pain, they just take the aspirin at home. They know to do that, so they start doing it. So find out if they've already had aspirin. Give it to them, give them a nitroglycerin, get them on oxygen immediately. Notify the hospital, this is EMS, that you got a STEMI coming in. And a lot of times CCC now, their pager gets a STEMI alert right away when the patient's coming in with a STEMI. What we find almost half the time is that by the time the patient gets here from EMS, it's not actually a STEMI, or the other hospital said that the 12 lead they got, like Sweets Belvedere, looked like a STEMI, they get here and their EKG is fine, that's not actually a STEMI. But sometimes it is. So we're going to check the vitals, like do all the stuff that you're supposed to do. EKG interpretation, if it truly is ST elevation, or they have a new bundle, a left bundle, and we strongly suspect injury, then we are going to get them to cath lab immediately. We've got that STEMI bundle where we try to get them within 90 minutes to the cath lab to open that up. And we won't go through reperfusion goals. So if you have ST depression or T wave inversion, that's indicative of ischemia. It very well may be that we need to get them to cath lab, but it's not a true STEMI, so we got a little bit more time to work with. So we're going to get the troponin. We're going to get labs anyway, any of these steps, but get the troponin, start giving them some medications, nitroglycerin, maybe give them a heparin, consider beta blockers, the G2B3A inhibitors, which would be like Riopro, Aggrastat, which we don't normally start. They don't start in ER. They're more likely to start it in cath lab. Admit to a monitored bed. These are a lot of your non-STEMI patients that they'll admit maybe to an ICU or maybe to the IMC, and then take them to cath lab scheduled for the next day, unless they start having EKG changes. And then this guy is just maybe they have a normal EKG with just maybe a little bit of changes, T-wave, and you're just gonna treat them, admit them to tele, maybe get an order, they're gonna go for a stress test or something the next day, but you suspect something cardiac is going on, but it's not a true MI, so you just follow that algorithm. EKG within 10 minutes of ED arrival, this is per the guidelines. If the patient has a STEMI, start them on the fibrinolytics within 30 minutes, and then get them to cath lab within 90 minutes, door to balloon time. Oxygen, again, right away. And it says signs of heart failure, shock, or SAT less than 94%. No, we just get them on oxygen right away. They're gonna need all the oxygen to the heart that they can get. Nitroglycerin dilates the coronary arteries, so we give them in 3 doses, sublingual if they need it, 3 to 5 minutes apart, until their pain goes away, hopefully it will, or until the blood pressure can't tolerate it anymore. Obviously, if they're already hypotensive with a blood pressure less than 90, or very Brady, although we don't always go by that, you might want to consider not giving nitroglycerin. Aspirin and NSAIDs, early administration, decreases mortality rates. Again, that's what you see, all these Bayer things. Everybody takes aspirin when they come in if they're having chest pain these days. They Googled it. Reduces coronary artery occlusion, ischemic events, effective with both STEMI and non-STEMI. Recommended dose is 2 to 4 baby aspirin. Give them morphine for the pain. Couple different reasons. Number one, morphine is a vasodilator, so that'll help decrease your blood pressure, because a lot of times if you're having an MI, you're going to be very hypertensive from the pain, from the anxiety, from the situation itself. So it's not only going to be an analgesic, but it's also going to be a vasodilator and help bring the blood pressure down a little bit if they need it. Patients having chest pains, treat with nitroglycerin first, because number one, it's a coronary vasodilator, and number two, it's probably going to drop your blood pressure, so if you give the pain medicine, at least at the same time or before, you really need the nitro more than you need the morphine, and you don't want to completely vasodilate them and drop the pressure. So MI, admission orders include giving the patient nitroglycerin, stat 12 lead, and then notify the physician. Get your cardiac enzymes. And what is really the most important or the most indicative enzyme that we can get that tells us the patient's actually having a heart attack?
Troponins.
Yep, troponidite. The limitation there is that they're insensitive during the first 4 to 6 hours. Again, we don't really care if it looks like they're having an MI, we're going to get them anyway, because that's why we get them serially, is that you want to see when it peaks, see how big the heart attack was, and then see when it starts to come back down. STEMI alert, and this is what Peoria uses. It's not necessarily what we use, but for the most part, it's pretty universal. So we get the EKG within 10 minutes, activate the STEMI alert, and this is ER doing this. I mean, you could do it in the hospital too, but this is mostly just a pre-hospital. I have no idea what a Hemo Q is, but get it at the bedside. Get your labs drawn. Keep the patient on bed rest, give the baby aspirin, heparin, most likely. We don't use this medication. Plavix, we're more likely to use. Clopidogrel, nitroglycerin, the sublingual, the morphine, and then make sure that the cath lab is ready to go. And our cath lab team has to be in the hospital within 30 minutes and have the cath lab set up for the patient being in there within 35 minutes of the STEMI alert, of the STEMI call. This is kind of just more of the same. I don't think we need to go through this either. This is kind of more beyond stuff. So, percutaneous coronary intervention with stents. Before we had drug-eluting stents, all we had was bare metal stents, and they're useful. And I don't need to go through that. You guys know when you put a stent in, it just helps to keep the vessel open. The drug-eluting stent, usually the medication that's on there is a chemo type medication. Like they'll give this chemo, and I don't remember the name of it, but it's the one that it's given for breast cancer, for lung cancer, those kind of things. And that just helps prevent the scarring tissue to build over the stent so that it doesn't reocclude. So these obviously work a lot better. It decreases the restenosis chances, and it makes them last a little bit longer. So, I don't want to say almost always, but we're definitely using a lot more drug-eluting stents than we're using the bare metal stents. And maybe you guys see this when your patients come back from cath lab having the angio-seal. I don't know what that is, and we don't use that here. And thank goodness they're doing this, but they're also doing a lot more of the radial approach too, which I love, and I wish they could do it on all of them. So you guys know have you had enough of the TR bands and know how to treat them? And they're gonna have the orders anyway as far as to when to let the air out. I won't go through that. Potential complications. Has anybody ever had a patient that had a retroperitoneal post-cath? Because it sucked.
I had a lot of people tell us recently, actually. Not on anything but around this, but.
Yeah. So we know all to look to see if there's a hematoma at the groin site, but then all of a sudden you don't see anything and your patient's hypotensive, severe abdominal pain or back pain. They're getting pale, more hypotensive, you get an H&H and it's down to 7, and you say, what the heck? Probably what's happening is a retroperitoneal bleed, if you've got those particular symptoms. And it's horrible pain, because blood is very irritating to everything inside. So if they're having that horrible pain, usually in their back more than their abdomen, really suspect a retroperitoneal bleed, tell the physician, maybe we need to get an ultrasound or get the patient down for a CT. Sometimes it's a surgical thing, sometimes we'll just clot off by itself, we just give them with the blood. If they're on heparin or something, we may stop that, treat their symptoms. Arrhythmias, have you guys heard of reperfusion beats? So what happens is when you've had a heart muscle that's been deprived of oxygen for any length of time, they start having, when it starts getting deprived of oxygen, they'll start having ectopy. You'll see a lot of PVCs, and that's just the cells that are dying and they can't, they don't get the electrical stimulus, so they start getting PVCs all over. Well, what happens is, and not with everybody, but some people, especially if they have a lot of problems with ectopy while they're having the heart attack, they're probably going to have what we call reperfusion beats after they have the stent put in. And you're just going to see a lot of VTAC, a lot of PVCs, and you call the doctor and say, potassium's fine, I don't know why they're having all these PVCs, and they're just going to say it's reperfusion beats, just watch it. Usually they don't treat it, and that's just the oxygenated blood getting to that dead tissue or that ischemic tissue, and it causes a shift with the potassium, or it just causes irritation with that blood that wasn't getting oxygen and now it is. It just causes irritation and you get this ectopy.
I was just thinking, we actually did have a retroperitoneal bleed recently on our
Yeah.
unit. Well,
It sucked, didn't it?
yeah, it did. Cause actually it really wasn't as bad, but I mean, once we found out, because the problem was she had a right groin, and then her hemoglobin levels were extremely low, but she was asymptomatic, but then they took her down for a CT, I believe, and it was a small bleed. It was really
Okay.
small, so it wasn't like humongous, and so we ended up having to transfuse her and everything. So
I will never forget the patient we had, and it's probably been at least 5 years, maybe even a little bit more, is a patient was, I believe on 2 South, and had a plasty, and then came to us because she was hypotensive, they couldn't figure out why, and got her over, and everything started to come together. She had a retroperitoneal bleed and died that night. It was one of those like slow building things until she was older. You know how you tolerate things until you don't, and then suddenly she just crashed, and there was nothing we could do. We couldn't treat her fast enough, and try to explain that to the family. It was devastating. It was horrible. And it was one of those things where she came into the hospital to get better, and we killed her. And it wasn't anything anybody did, but because you can't see the retroperitoneal bleed until you start getting symptomatic. And with her, She was old, she had a bad heart, and she just couldn't tolerate any insult at all. And the drop in hemoglobin just put her over the edge. Okay. Doesn't happen very often, but you can reocclude the stent, even the same, couple hours, couple days after the stent's been placed. You can have reocclusion. Antiplatelet therapy, we're seeing a lot more of the Brilinta and the Xarelto, and as Carrie alluded to, we now have reversal agents for those. We'd have those patients that came in having an MI and need to go for emergency bypass, but we couldn't do it because they had been on Xarelto, and if we took them to surgery, they were gonna bleed out, so we'd have to wait and let them have their MI, or do we could. So now, just within this past year, they've come up with reversal agents, so that's excellent. Plavix, you guys are all probably pretty familiar with those medications. I think that's gonna be that in there. Yeah, like, okay. And then this, I'm gonna go over hemodynamics, it's this one, some more of the blue. And the reason I'm just doing a quick thing on hemodynamics because again, you guys will probably be having CVPs and art lines. I don't know how often, but you're gonna have the capability. So, you guys probably aren't very used to having transduced CVPs or transduced art lines, used to getting them and then pulling them as opposed to monitoring their blood pressure, hemodynamics with them. So we'll go over this a little bit. And just go to slideshow. And then start from the beginning. Okay. Hemodynamics 101. So hemodynamics is basically a branch of physiology that deals with circulation of the blood. It's the force or mechanisms involved in circulation. But what you need to know is that our goal is to optimize hemodynamics. And I say that because there are times when we've got all these parameters, all these normals for patients, but we never get them to normal because they're just too sick, their heart is too bad, something. You can never get normals out of these people, but you want to optimize them and get them back to homeostasis as quickly as we can. And the ultimate goal is for adequate tissue perfusion, which we kind of talked about with the sepsis as well. So the purpose of hemodynamic monitoring, and when I say hemodynamic monitoring, I'm not only just talking about the CVP and art line, which you guys will be seeing, but I'm also talking about our eyes and ears. We don't have to have this technology, which we have our fingertips on. We just need to also do our own assessments of the patients. And I'll go through that in a second, but those are even more important than these hemodynamics, which are only good as the user or the equipment. So we want to evaluate the cardiovascular system, pressure, flow, and resistance. And I say that because there's a difference between pressure and flow. When we're talking about blood pressure, we're talking about an actual pressure. We're not talking about the volume of the status or even the flow. And when we're talking about flow, we're not talking about pressure. So you can have the same volume in a person, but their pressure is going to be different. And that's inside the vessel I'm talking about. I'm not talking about blood pressure necessarily, but the pressure in the vessel itself. I have the same volume. People are going to have a high resistance, high pressure, low pressure. And conversely, I could have a patient who has, two people have the same blood pressure, but one is hypovolemic and one is hypervolemic and one is normalvolemic. So they're two completely different things, but we kind of in our heads use them as the same thing. We think of them as the same thing. But I want you to start getting out of that. For an example, if I've got a patient who is hypovolemic, they come in, they're dehydrated, they were at home, didn't feel well, stopped eating and drinking, and they were hypovolemic. I may have a good blood pressure. My blood pressure may be 120/80, but that's only a compensatory mechanism. I'm gonna be tachycardic with that, because what my heart's gonna do is speed up to try to increase my cardiac output to compensate for the low volume. So, my pressure may be fine now, but, I'm still not getting and that's just a compensatory mechanism. I still might not be getting good perfusion in my kidneys, I might be pale, I might be lethargic. That's just compensatory, and eventually that compensation is gonna run out and your patient's gonna crash. So that's what I mean, the difference between, you could have a good blood pressure because your body has a great way of compensating until it won't. So that doesn't necessarily tell you what your volume status is, and that's important. Establish the baseline values and evaluate the trends. Similar to Carrie, the take-home message here is trends. Pay attention to what your vital signs, what your assessment of the patient is at the beginning of your shift, and if you see trends happening, pay attention to them, because that body is telling you something's not right and it's going on. And it may be super subtle, but by the end of your shift, and you're giving a report, you're like, well, shoot, you know, his pressure was fine, and now it's on the low side, so maybe we need to call and get some fluid. But you never really, it was so subtle, you didn't really pay a whole lot of attention to it during your shift because you were so busy and it just kind of crept up on you. So pay attention to trends. Determine the presence and degree of dysfunction and implement and guide interventions early to prevent the problems from happening. Hemodynamic monitoring is your baseline data, and this is why I'm talking about using your eyes and your ears and your critical thinking and your general assessment skills. Because this, you're gonna see even more when you're assessing their general appearance, their LOC, their skin color and temperature, their vital signs, their pulses, their urine output. For instance, with the hearts, we've got all this monitoring equipment, we've got swans, we've got art lines, we've got Foleys, we've got everything, we're looking at all the numbers. But if I call a doctor because just one number's out of parameter, say, my blood pressure might be 88/60, and I have an order to call of less than 90. And I'm gonna call, and he's gonna say, is he awake? Yes. Does he have urine output? Yes. Is his skin warm and dry? Yes. Is he mottled? No. Then don't worry about it, because that's just one number, and it might not mean anything. Now maybe if it's trending the wrong way, I'm gonna start paying attention to that, but for now, just one number isn't gonna tell you a whole lot. You have to look at the big picture when you're talking about hemodynamics. And those are the things I'm talking about. Monitor the urine output, look at their skin and is it warm and dry. Their LOC is gonna tell you a whole lot, because they're gonna start, if perfusion is starting to get worse, their level of consciousness, whether they're confused or getting more lethargic, you're gonna start seeing that pretty quickly. Let me change this. Let me go here first. So central venous pressure monitoring. Again, going back to, and that's for the central line where we can transduce it. And the central line kind of sits in the superior vena cava. It doesn't go all the way in the right atrium, but what we're doing when we're monitoring it, theoretically, is monitoring the volume status, and that's why doctors will usually say transduce the CVP. Maybe the patient's dehydrated, their pressure's down, they've got a CVP, so let's just look at what a CVP is, and if it's low, and I'll go through that stuff in a second. If it's low, maybe they need a fluid bolus or they need some blood. If it's high, maybe we need to give them a diuretic. But again, the difference is I could have a perfectly normal volume status, or even say hypovolemic, and my CVP could be high because the CVP is monitoring a pressure. And if I'm all clamped down because I'm hypovolemic, that's my body's response to having a low volume, is to clamp up, so you have less space to fill that blood with. I'm gonna clamp up, my pressure is gonna be elevated because of that constriction. That tells me nothing about my volume status. So you're gonna find, you're gonna hear the research is telling you that the CVP with the sepsis guidelines, with how you treat your patient, the CVP, which we've gone by for years, as long as I've been a nurse, is kind of going out of favor because it doesn't really tell you a whole lot. What you can look at is the trends. If I came on and my CVP was 8, normal is 2 to 6. That's a normal person's CVP. If my CVP was 8 when I came on, and then it's 6 a few hours later, and now it's 2, and now I have no urine output, and my blood pressure's in the 80s. Watching those trends, that's usually gonna tell me that I'm probably getting hypovolemic and I need some fluids. Does that make sense? Not really? When you, and this will make more sense when you start going around with the nurses in the ICU, because we've instructed them to give you the kind of patients that you'll have in the IMC with the central lines and the art lines, the kind of patients that you'll see. So when you see it firsthand, the central line and the CVP, it'll make more sense. What else? Arterial line, we'll go through that in a second. EKG, just remember, single hemodynamic values are really significant. Look at the trends. I'm gonna go back up here a second. So this is, and I just thought this was interesting. They compared hemodynamics to an IV pump. And I'm gonna go through preload and afterload here in a second. They talk about fluid that's going in an IV as kind of the preload. And this is the heart. So this is where the preload comes. So any fluid that I've got, or any blood I've got coming to my heart after it's circulated through my body, coming back into the right atrium and the right ventricle is called preload. Actually into the left ventricle too, because we want it in left ventricle, that's what goes out to the heart. So any blood I have in my left ventricle right before systole, right before I squeeze it out, is called preload. So if I'm hypovolemic, my preload is going to be very low. I'm going to have a CVP of 2 or less. So if I have less fluid in my heart to pump out, I'm not going to have enough oxygenated blood with all its nutrients pumping out to the rest of the body. My blood pressure is going to be low. You're going to see a bump in your BUN and creatinine because the blood isn't getting out there and there isn't enough of it, so we need to get more of it. So low preload, which is going into my heart, is really what we're monitoring with the CVP. The IV pump is the cardiac output of contractility, and it needs electricity. So contractility is just the heart itself and how well it's able to pump out that blood that's in there. I could have a normal preload, I could have enough volume in my status, and then it gets into my ventricle, but if my ventricle is really stiff or it's not working well, if I have cardiomyopathy and it can't pump it out, then it's not going to do me a whole lot of good either. So this is maybe where the problem is in the heart. And then the tubing itself is the afterload. So afterload is after I'm in my heart, I'm pumping it out, I'm going through my aorta, and now I'm going through the aorta to the rest of the body. Afterload is the resistance that the heart has to go against to pump it out. So for instance, if I'm really hypertensive and I'm all constricted and there's a whole lot of pressure out there, everything's clamped down, my heart obviously is going to have a harder time pumping that blood out. So what I need to do is, if my blood pressure is super high, my heart has to work overtime, and that's what happens with cardiomyopathy. Those patients, that years they've had hypertension, and now they come in and you find out that they have cardiomyopathy because they've been working so hard pumping against that resistance, and that resistance is the afterload. So if I can get that afterload down, my heart doesn't have to work so hard to pump the blood out. Does that make sense? Okay, so you're going to see numbers or words like preload, which is a CVP, and afterload, and you won't have to memorize. That's the SVR. There is the systemic vascular resistance, and that's the afterload we're talking about. So we use the CVP to monitor the volume status again. It kind of very indirectly tells us the volume of the left side of the heart, or the volume in all of the body, because really it's the only thing we've got. Aside from using our general assessment, is the urine output low, that kind of thing. Anything else is going to skim trigger, if it's going to tell me I'm hypovolemic, we're going to use that. So CVP, again, 2 to 6 is normal. If the CVP is elevated, it could be that they're overhydrated, heart failure, if they're working really hard to breathe, increasing that interthoracic pressure if they're having a COPD exacerbation, and I get all that, pressure from the COPD, that's gonna squeeze everything in there, and that's gonna increase the CVP. And you don't have to memorize all this stuff, I just wanna give you an idea of what we're looking at for it. And then decrease in CVP is hypovolemic, fluid shift, dehydration of any kind, and then a negative pressure. Won't go through any of that. CVP catheter is also a treatment tool which allows for rapid infusion. We want to put a CVP in for those patients who need volume or blood rapidly, or if they have really bad veins, obviously, and we want to get fluids in them, but their veins, all I can get is like a 24 in the thumb. Infusion of hypertonic solutions. There's a lot of medications of dopamine again. If you think your patient's going to be on dopamine, you want to get a CVP in them if it's going to be in for any length of time. And then we can also draw blood off of that. So if they're getting a lot of lab draws and they don't have, veins to stick, it'd be a good idea to get a CVP as well. Arterial pressure monitoring is continuous blood pressure monitoring and lab drawing. Most important thing here is if you have one that's transduced, never ever ever turn the alarm off. You'll find those patients that they have a radial art line in, and sometimes depending on how they have their arm, it'll cause a dampening of the waveform, and then it'll alarm, and you get tired of it, so you turn the alarm off. Well, meanwhile, they've pulled that art line out, and now they've exsanguinated because you aren't in there 24 hours a day, every minute watching them. And, they code, and you walk in there, and there's blood all over the place. So, because you guys aren't used to monitoring alarms or art lines, keeping them in there, just remember that you always have to have an alarm on that, because what that'll tell you is if they do pull it out, it's gonna read 0, because now they don't have a systolic and a diastolic, it's just gonna read 0 with a flat, and it'll alarm, hopefully alert you to go in there and check on that patient, because either they're dying, or they're coding, or they pulled their art line out. So, never ever turn the art line off, we've been burned by that before. And then, alarm parameters are set to the patient's baseline, and this is just a thing because I'm on the alarm fatigue committee, is if you have a parameter for a blood pressure keep greater than 90, like 90 to 140, let's say, and you've got your alarm set so that it'll alarm if it's 100, or if it's, whatever, it's out of the parameters, and it just keeps alarming and alarming because you haven't adjusted those alarms to the parameters that the doctor wants. That's when people stop hearing alarms. And if you've ever worked over in CCC, you hear all of the alarms that go off constantly. 90% of those probably, and that's an arbitrary number, I just made that up, but a lot of those are because the nurses haven't adjusted their parameters according to what that patient, like they'll have the AFib alarm on and the patient is chronic AFib. So every 10 minutes, it's dinging that the patient's in AFib. We're obviously not doing anything about it because they're chronic AFib. If you would just shut that alarm off, then it wouldn't ding. And that's when people stop hearing the alarms because they just go off all the time. So that's just my own little soapbox. And this is just a picture of the waveform, and I've got another one here. So when your aortic valve opens, the upstroke of the art-line waveform shows the blood going into the aorta. That's your maximum pulse, is your systolic. When you get down to where it says the aortic valve closes, and you'll see it, this one doesn't really show up, but have you ever heard a dichrotic notch? That's where the aortic valve closes, and you'll see a little bump in the waveform, which I'll show you in a second. That is when the pressure in the aorta exceeds the pressure in the, is that right? In the ventricle, and it closes. Yes. I gotta think about it again. So here is where the pressure in the ventricle exceeds the pressure in the aorta. It's ready for systole. The aortic valve opens. You get all the blood, and now the aortic pressure is decreasing, so it closes, and this is where all the blood starts to fill back into the ventricle, and it's getting ready for systole again. And that's your diastolic pressure. So this is what it's going to look like for you guys. You're going to have your EKG. This is what your art line is going to look like, your waveform. This is a dichrotic notch where the aortic valve is closing, and you see the little blip. That's called the dichrotic notch. so that's normal. And then this is what a CVP waveform looks like. And what this is measuring is your right atrial pressure, because it sits in the superior vena cava. So what it's directly measuring is a right atrial pressure. What it's indirectly measuring is the volume status and technically the pressure throughout the body, but we can't do that. So we measure the CVP. And it's because your right atrial pressure is so little, I mean, it doesn't take much for the right atrium to squeeze blood into the right ventricle. It's very low pressure. It's just a tiny little waveform. And this is 6, so that's normal.
What is the range again?
2 to 6. And I'm on vacation. It says Cub win and Marla's on vacation. Any questions about that?
Doing so good.
Are you saying go Cubs go?
Yes. I'm totally excited to this.